o'clock. Hello, everyone, and welcome to the American Foregut Society webinar on therapeutic management of gastroesophageal reflux disease. We're very lucky tonight to have our panelists and discussants with us. We have Dr. Ellen Stein from Johns Hopkins. We have Dr. Magnus Hallen from the Mayo Clinic in Rochester and Dr. Brian Smith from UC Irvine. We'll be kicking it off with Dr. Stein, followed by Dr. Halland. And then moving on to there, we'll have a discussion and question and answer session. So without further delay, Dr. Stein.
Hi, I'm Dr. Stein. I'm just gonna get my screen to share and we should be ready to go. So tonight I'm gonna be talking about therapeutic approaches to GERD, PPI strategies, and risks and benefits. I'm an associate professor and I've been at Hopkins for the last 10 years and I work in motility. I have some financial disclosures. I've received some consulting fees from Takeda and some funding from the Rome Foundation. So I have a patient and I like to bring a patient into this because this is how it goes in practice. I had a 79-year-old male with achalasia treated by Heller about 15 years ago, had a loose toupee at the time, but now he's got worsening dysphagia. And we were trying to sort out whether it was achalasia or reflux. And he was really worried about his PPI use, and both he and his primary care doctor talked and they stopped all of his PPI medications, and he had had reflux for many years. When we finally got him to endoscopy, he had a 7-millimeter wide stricture at the EG junction, which has been refractory to dilation. And he and his wife are very worried about the risks of PPI therapy. And no matter what I said for a while, even carefully counseling him, I couldn't convince him that he really needed that medication for the strictures to heal. And without his true esophagogastric barrier, which was destroyed with his Heller surgery, he was really at risk for reflux with his toupee, and with his age and other comorbidities, he wasn't a candidate for surgery. So here's what I told him. So there are benefits of PPI therapy. You know, there are few people who really require PPI therapy per the FDA guidelines. It's meant for healing of erosive esophagitis, maintenance of healed erosive esophagitis, treatment of GERD, risk reduction for gastric ulcer associated with NSAIDs, H. pylori treatment, your hypersecretory conditions, and short-term and maintenance treatment of duodenal ulcer. There are FDA and NICE guidance and guidelines from consensus groups on PPI use, and they recommend for long-term use of PPIs that you can use it for healing of erosive esophagitis and maintenance of healing, for GERD, NERD, and extraesophageal symptoms, including esophageal strictures and Barrett's esophagus, like my patient. You can use it for NSAID-induced dyspepsia, for healing of and risk reduction of NSAID-associated gastric ulcers, for your hypersecretory conditions, critically ill patients on prolonged mechanical ventilation. So in these patients, what is the level of evidence for use? Well, it's all moderate to high. There is moderate to high level of evidence for long-term PPI use from both observation and randomized controlled trials. And this was summarized in a great article by Freeberg that was published in Gastroenterology. So when we look at PPI therapy, there was a meta-analysis done of data from more than 1,200 randomized controlled trials looking at the main gastroprotectant drugs in current use, which indicated almost 200,000 total participants. And they showed in some that gastroprotectant therapies are effective for the prevention and treatment of peptic ulcer disease and its main complications. So up here, this is the prevention trials. These are patients who were at risk and on NSAIDs for symptomatic ulcers and bleeds, and there was less likely to have a ulcer or bleed when they took PPI therapy. Here we have people who had a bleeding ulcer on NSAIDs, and healing was more likely on PPI therapy. So PPIs work to heal mucosa and to avoid the complications of reflux, and we've got really robust data that supports that. So now, what are the perils of these pills? They're all over the news, and I'm going to explain why the news is old news, bad news, or fake news. And this is what I tell patients. So the absolute excess risk from PPIs is very low for nearly all of the reported effects. There's chronic kidney disease, dementia, bone fracture, myocardial infarction, small intestinal bacterial overgrowth, enteric infections, and spontaneous bacterial peritonitis, C. diff, pneumonia, micronutrient deficiencies, and malignancies. When the news quotes the studies, they always include the relative risk because it sounds super fancy. 10 to 20% risk, 40% risk. but the absolute excess risk is low because these things are uncommon. So increasing a very uncommon thing, it's still uncommon to happen. And the Freeberg article put together this really lovely table. Now there are two that I'm going to focus on, two risks today: chronic kidney disease and spontaneous bacterial peritonitis. There is a little bit more of a signal for these two adverse effects, and I'll talk about them in just a moment. So renal insufficiency happens from many medications that are used. And there is an acute interstitial nephritis that can happen when you have a drug allergy. It rarely occurs, but it can result in significant renal dysfunction. So if a patient is on a medication and they develop renal insufficiency, it's up to you and the nephrologist to sort out which medication that is. It's very hard to do a randomized controlled trial on this issue because it's only happening about 8 per 10,000 patient years. So that's a lot of patients that would need to be enrolled in a study. Now, we have some data from the ERIC study, the replication cohort at Geisinger, and the Swedish study that I'm going to go over. So there is a substantial population that is at risk for kidney disease, and there's a lot of work being done to modify those risks. And as part of the studies looking at what causes the risk of chronic kidney disease, the ERIC study had a 10-year estimated absolute risk of chronic kidney disease that was shown among their 322 baseline PPI users to be 11.8%. But the expected risk, had they not used PPIs, was 8.5%. So they found an increased absolute risk difference of 3.3%. There was a cohort in Geisinger with many thousands of patients, 16,000 baseline PPI users, and they had a risk of 15.6%. But the expected risk that was predicted if they had not used PPIs was only 13.9%. Again, an absolute risk difference of 1.7%. Swedish study, this included some cohorts of twins and looked at people, more than 50,000 people over many years, and they found both a graded association between cumulative exposure to PPIs and risk of chronic kidney disease progression, but this was not the case for cumulative H2 blockers in use. Now, many of these studies, the indication for people to be on PPI was that they were on NSAIDs. And as we know, NSAIDs do cause chronic kidney disease. So there's a little bit of confounding in this population, but it's big enough of a risk that they're looking to do greater studies to find out if there's real risk. I had a patient who had one kidney, and that's somebody you need to take seriously. If their kidney function declines and they have one kidney, you may need to change your medications. So now let's talk about cirrhosis. There are known risks of cirrhosis from taking PPI use. PPI has been associated with hastening decompensation of cirrhosis and increasing risk of spontaneous bacterial peritonitis, as well as increasing overall mortality. And the AASLD is now recommending to avoid unnecessary use of PPI in cirrhotic patients. At this time, we find in the table on the right that the PPI users marked with the yellow arrow had an increased risk of death. I'm not sure what could be more clear, but to me, this is pretty decent evidence that in cirrhotics, if they don't have a high quality indication, they shouldn't be on a PPI. And if they do need the PPI, you should really be having a discussion and an ongoing conversation with their hepatologist to find out what you can do to mitigate those risks. Now, my patient, who was in his 80s, was very, very worried. He had a family history of dementia, and he wanted to know about dementia. So in multiple studies, now 3 consecutive large-scale population-based studies, there is no dementia risk associated with long-term PPI use. This was from the Journal of the American Geriatric Society, and then there was a gastro article, as well, or a CGH article, as well as an American Journal of Gastro article. And in each of these large-scale studies, including twin studies, long-term use of PPI was not associated with any kind of cognitive decline or Alzheimer's. And I framed this and I bring it to my clinic to show it to my patients because this is really something they are very concerned about. But the good thing is that there is no known risk. So remain vigilant for the few valid risks of PPI. Most of the study data on risks, when re-examined critically or restudied, doesn't hold up very well. There are legitimate risks for cirrhotics. There are legitimate risks for renal issues, and you shouldn't ignore renal insufficiency in patients on PPIs. All of the other alleged associations are just that. They're alleged associations right now, and they're unlikely super significant. There's no grade 1 evidence at this time about those risks, there's only grade 2 or 3 evidence. I still only use PPI in patients who will have a benefit. I use the lowest effective dose and I taper when possible. Now let's talk about the perils of just throwing pills at patients. Well, without combining PPI use with a healthy lifestyle and other medications and changing how they eat, you're really not going to make a good effect on their symptom control. So timing the PPIs correctly is one of the things I frequently see that patients were not advised to do. Leaving 2 to 3 hours between meal and bed, avoiding high fat or junk foods, eating smaller meals throughout the day rather than a very large meal in the evening, making lunch a bigger meal. Try the Mediterranean style diet is what I've always told, and I'll talk about that in a minute. And then skipping the extra glasses. If you ask your patients on average, I ask, how much coffee do you have? And the other day somebody said, well, I have 48 ounces of coffee a day. There is nothing that I can do on earth that will combat 48 ounces of coffee a day. So guiding your patients to skip those extra glasses will really be helpful. This is a study that was published in the Washington Post, and in a Mediterranean population, the Mediterranean children who stopped eating a healthy Mediterranean diet became obese in Europe. And so this is why it's so important. And I am very pleased to say that CNN has done something good. And I love Stanley Tucci. He made his big premiere in Big Night many years ago when I was young. And I actually prescribe his show to patients right now. He features the Mediterranean diet, leisurely meals, healthy portions, balanced diets, a diet rich in fresh fruits and vegetables, fresh meats, time spent with family, and much of his day is spent walking. And that is truly the combined Mediterranean diet. And all those things would be very helpful for someone with any kind of reflux symptoms, basically anybody who's been through the last year of COVID. So in medical management, we talked about the PPI therapy. We also have H2 receptor antagonists. There are the antacids like aluminum hydroxide, calcium carbonate, magnesium hydroxide, and sodium bicarbonate, your alginate barriers, and SSRIs and TCAs, which can all be used in combination to help relieve symptoms. Now, Zantac was removed from the market, and I'll talk about that in a moment. When you compare PPI therapies, one of the frequent questions that we get is, how common is it for one PPI to work better than another? Well, this table and study by Graham and Tansel shows the relative increasing potency in terms of omeprazole equivalents of the PPI therapies, starting at the lowest, which is pantoprazole, and increasing to the highest, which is rabeprazole. In actual practice, I usually prescribe the one that your insurance covers the most because I find that for most patients, they are equivalent. There are some patients who do report a difference between different medications, and these people may have some differences in their CYP processing in the liver, and so this may become important for some of the patients. They also studied the cost at the time of different formulations, generic and brand name. I don't know if this is still valid. It seems like every year the prices change so dramatically and without reason, but it is helpful to know, at least at this time, that there's a wide variation in the cost, and it doesn't always have to do with the omeprazole equivalent. So you may be able to get a better drug for lower cost if you look for it. Now, the Zantac recall or ranitidine recall, there was a recommendation to stop Zantac and ranitidine in all patients, especially those without an indication, because there was NMDA contamination within the Zantac production lines, and it's expanded to several of the other H2 blockers. The recommendation was to switch to an alternate H2 blocker, and I haven't heard that these have returned to the market at this time. So when a patient doesn't have improvement on PPI, they've tried their lifestyle changes and all the other things, what are you going to do? So I clarify, was their medication optimized? Did some of their symptoms resolve? Because maybe you did make a difference, but there's something else that's really bothering them. And then finding out what bothersome symptoms remain. Again, you could use all the PPI in the world, but if somebody's got a very large hernia, that probably needs to be addressed. And you cannot treat that completely with PPI medications. So if there was no improvement of any symptoms, really have a high index of suspicion for an alternative explanation, such as a functional or motility disturbance. And maybe alternate testing is warranted. So in the primary care algorithm for evaluation and management, most of the time people get a PPI trial, GERD is suspected, and then they come to us. And it wasn't always clear what we should do. Because after a PPI trial, if somebody's feeling better, it can be really hard to convince them to stop. So diagnostic methods exist, and I won't go deeply into this because I know other sessions will focus on it, but Bravo pH testing, pH impedance testing, both offer a chance to get a glimpse at what's going on. And off therapy testing can really show you whether there is baseline reflux. So testing earlier is now one of the diagnostic strategies to consider to make a confirmed diagnosis before long-term PPI management is considered. Other testing may be needed. I referenced this earlier, such as time to barium swallow, and esophageal manometry and esophageal planimetry, depending on the constellation of symptoms that the patient's reporting. And in the care pathway for GERD, actually from the AGA, esophageal pH testing to establish pathologic GERD as a diagnosis is a recommended step before pursuing manometry and barium radiograms. So there are surgical and endosurgical options, and I frequently use them. I think they're best used in combination with PPI therapies. There's Nissen fundoplication, partial fundoplication, the sphincter augmentation with a magnetic sphincter, the sphincter augmentation with an endoscopic transoral incisionless fundoplication, and in some cases when there's a hernia, a combination with a hernia repair. If the BMI is very elevated, then we would always consider a gastric bypass. So in my patients who are on PPIs, not doing very well or not getting complete symptom relief, that's when it's time to start thinking, is there a hernia present or absent? Is there esophageal motility? Is it working? Is it effective or is it weak? Were there multiple prior surgical interventions? Maybe something has slipped or come undone. If there's obesity, I always counsel patients that losing 5 or 10 pounds may have a dramatic effect on their symptoms. And then looking for a concurrent history of another motility disorder, such as bloating, gastric emptying delay, is very helpful because you can do symptom-directed therapy for those symptoms. Now, I'm going to end on these last two slides. So Dr. Yadlapati published a very lovely study and review, and she looked at what was a double dose PPI trial. So for patients with troublesome GERD symptoms despite a single dose PPI, they gave 8 weeks of double dose PPIs. And then if there was no symptom response, they assessed for objective GERD despite the double dose PPI. So an endoscopic finding of LA grade C or D esophagitis, peptic stricture, Barrett's esophagus, or a pH impedance on PPI therapy with elevated acid exposure or reflux burden. And those patients were defined as PPI refractory GERD. So in these patients, what should we do? Well, you've already tried PPIs at max doses, so you could switch PPIs. But this study actually looked at some of these patients, and it was a very excellent study. And I'm pretty sure it's been discussed before this year. Stu Speckler and a whole series of people from the VA took these patients at the VA gastroenterology clinics who had PPI refractory heartburn as defined previously. And they did a systematic workup which revealed those who were truly PPI refractory and those who had reflux-related heartburn that was diagnosed. And this actually was present in only a minority of patients. But for that selected subgroup, surgery was superior to medical treatment in a way that was relatively unexpected, because previously these patients would have received many neuromodulators, cognitive behavioral therapy, but in this subpopulation where they could confirm a correlation, surgery was really helpful. As we know, surgery doesn't mean that you will stay off PPIs forever, but as an adjunct, this is a really dramatic response. So in summary, make a diagnosis that's solid using testing when indicated. Make sure that PPI for appropriate patients is continued, and inform your patients of how it is a safe therapy and it's an effective therapy. Surgical options exist, and you should exclude contraindications before offering them, but you shouldn't hesitate when somebody's got a coexisting hernia or other disease to kind of go forward with that kind of intervention. Now, there's more to come on newer medications in the next several years. Vanazepam is available in Asia and is now in phase 3 studies, but it is not FDA approved, and this will offer a new class of therapy potentially for these patients. So I'm very excited for the future of reflux management. Thank you.
Thank you, Dr. Stein. That was excellent, comprehensive, evidence-based evaluation of medical management for GERD. we're going to move on now to Dr. Howland. I think he has some interesting topics to add to what you just discussed. Dr. Howland.
All right, well, good evening, and thank you all for being here. And wow, Dr. Stein, that was really a tour de force of PPIs in 20 minutes. I've seen many iterations of talks on this topic, and that was really a nice review. So I'm going to talk on a slightly different topic today, because our patients that suffer with reflux symptoms are out here to get helped. And when they seek help, I think it behooves us as physicians to think about all the available treatment options that we can give them. And in my practice in particular, I always focus on whether we can find a lifestyle or non-drug treatment for our patients before we consider drug treatments or surgical treatments. So today I'm going to talk about the topic of diaphragmatic breathing as a potential therapy in reflux disease. And unfortunately, I don't have any financial disclosures to make. Anyhow, okay. So the treatment paradigms has already been touched on tonight. Really, the treatment of reflux disease is divided into lifestyle treatments, medication treatments, or what I would call mechanical treatments. And all of these treatment options have potential pros and cons that needs to be considered. And selecting the right patient for the right treatment for the right reason is really key. So for example, if we look at current lifestyle changes, we have many that are highly effective. For example, weight loss, radically effective for helping patients with reflux, but really, really hard to achieve. Other things like bedhead elevation and avoiding late night eating can also be very helpful, but compliance with these things can be difficult, even in a pandemic when it's hard to eat at a restaurant. What about medications? Like we've just learned, they are incredibly safe. And they are very good at addressing one of the major symptoms of reflux, which is heartburn. But like Dr. Stein pointed out, many patients have inadequate symptom relief with medication because it doesn't address the pathophysiology of reflux disease, which is that a volume of gastric material is returning back up into the esophagus. Remember, gastroesophageal reflux disease is not a result of hypersecretion of acid. And yet a lot of the therapy that we give is an acid suppressive therapy. And like she mentioned, there is real concerns for some side effects, at least in long term. And even if they're uncommon, with such a common disorder and with the great number of people who take these medications, even a small real risk could be a real concern on a population basis. And then we have surgery or a mechanical solution for reflux, which can be highly successful if there is a major anatomical disruption to the gastroesophageal junction. And so that would be your hiatal hernia patient. That would be a patient with regurgitation, but it comes at a price. So bloating, inability or reduced ability to belch and vomit can be problems for some patients. Early satiety coupled with diarrhea can be issues. Gastroparesis is rare with highly trained surgeons and good surgical technique. That can also happen. And long-term success is also very challenging, with a recent Swedish study suggesting that nearly 100% of patients that had a BMI over 30 eventually ended up on PPI therapy again. So why on earth might diaphragmatic breathing help? And I think the concept to get into here is really that we think of reflux as a disease involving the distal esophagus and the proximal stomach. But if we look at the anatomy, we have the diaphragm right there. And we have the esophagus traveling through a small opening in the diaphragm called the crura. And that's a muscle. And it's a muscle under voluntary control. And we know that if you engage voluntary muscles, we can change their function. And you can even change structure of a muscle if you exercise it enough. So I don't think it's too out there to hypothesize that doing something about the diaphragm may have an impact on gastroesophageal reflux disease. The other thing that I think is important to keep in mind is highlighted here in now a study that people of my generation would call ancient, where Dr. de Meester and crew looked at different patterns of reflux disease once they started doing physiological testing with pH catheters. And what they noted, and what this diagram shows you, is that we have different phenotypes of reflux. We have some patients with reflux that have a bunch of acid exposure in their esophagus during the day, but when they go to sleep at night, not much happens. Then we have people who have a predominantly supine form of reflux. So, when they lie flat, they really have significant acid exposure. And then we have mixed refluxes that it doesn't matter which position they're in. They have reflux all day and all night. And that's really curious if the only explanation for reflux disease is a weakened LES or a mechanical defect in the esophageal gastric reflux barrier. It doesn't provide a good framework for explaining purely upright reflux. So here's a diagram that's going to dive into this a little bit further. And I know that this diagram is a little bit small, but I'm going to walk you through it. We have two panels here. On the left, we have a 24-hour pH study. You're seeing the entire 24 hours. And the pH catheters that I use have a distal pH sensor in the stomach. They have a proximal sensor in the esophagus, and then we have some impedance leads. And what you're looking there marked with red, just below there is the esophageal pH tracing, and you can see all these little red reflux events occurring. Then the patient goes to sleep, and it's marked by the supine marker that the patient presses. And I'll put a yellow marker on it to tell you that they're sleeping as well. And we can tell from this swallowing frequency that they're actually sleeping. And this patient just stops refluxing. And they wake back up again, and the reflux just starts right back up. And if you contrast that with this person here that doesn't have much reflux during the day, but they're vulnerable to reflux at night, and when they get up again, they stop refluxing, I think it's fair to say that not all patients with gastroesophageal reflux disease suffer from the same pathophysiology. Another clue that the diaphragm might be important comes from the treatment of rumination syndrome. So for those of you who are not overly familiar with rumination syndrome, it's one of the most curious GI disorders that we see, because we see patients that eat a meal, and within minutes, typically the food that they just ate returns back up into their mouth, and there it is. They either have to spit it out or they have to swallow it back down again. It's a very unpleasant disorder. And when we have treated rumination syndrome with diaphragmatic breathing, like in this diagram, we've done this with a manometry catheter down, and we have given people a meal with the manometry catheter down, and then we've exposed people to diaphragmatic breathing. And what this graph shows is that we can reduce these postprandial regurgitation events in patients with rumination syndrome by simply manipulating the diaphragm with diaphragmatic breathing. Here's an example of what it looks like on a manometry. And for those of you who are not familiar with the manometry, this is a pressure probe that also has impedance sensors. We place it down the esophagus, and now we have a perfect view of what's happening in the esophagus, both from a pressure perspective and from a flow perspective. And the pink material here is actually liquid impedance material in the patient's stomach. And you can see a marker there, LES, the lower esophageal sphincter. And you can see in a 5-minute period here after the patient eats, marked by the yellow stars, you can see this impedance material just shooting up, almost like that volcano in Iceland going off at the moment, returning up into the patient's esophagus. And then in the middle part of this slide, we instruct people to do diaphragmatic breathing, and we can calm this whole process back down. And then we take away the diaphragmatic breathing, and it starts back up again. So clearly, manipulation of the esophageal gastric junction by the means of diaphragmatic breathing has a potent effect on regurgitation events in rumination syndrome. But will it work for GERD? And so after I did that study, I came up with the idea that I should do a trial for diaphragmatic breathing in GERD. And usually when you have a bright idea in medicine, it's wise to check if somebody else has done it first, because usually somebody else has had the same thought as you, earlier than you, and maybe even done a study that's better than yours. So I looked into diaphragmatic breathing for GERD, and there wasn't all that much out there. I could find 2 relevant studies. One was done by Dr. Eherer in Austria, and he took patients with reflux disease, and he instructed them in diaphragmatic breathing, and he had them do it for a month. They did it a couple of times per day. Apparently, they only did it for 5 minutes. And then what he did a pH study, and he did a pH study at baseline And he did a pH study a month later, and he demonstrated that you could reduce the degree of esophageal acid exposure in a number of patients, as you can see on the graph on the left here, in the training group, doing better than the no training, which was his control group. Then we have Andrew Ong, who works in Singapore, and he is interested in patients with reflux who also belch. And he instructed these patients in diaphragmatic breathing. He actually shared a beautiful video of this that accompanies the article that is freely available for anyone who wants to see how this was done. And when he treated supragastric belching, reflux symptoms in that population were also reduced using many of the validated reflux symptom questionnaires that we use. So what did I do? Well, the study that I wanted to talk about today is a study that was recently published in the Red Journal, where we really wanted to look at the mechanism of action and the efficacy of diaphragmatic breathing in reducing reflux events, while at the same time assessing the lower esophageal sphincter and the gastric pressure after a meal. And we also wanted to do a prolonged ambulatory period. So it was an ambitious study, it took a long time to do. And thank you to my wife and children. It's two years of my life that I'll never get back, but here it is. So who did we include in this trial? Well, you can imagine if you think back to the first few slides that I showed you, I don't think this technique would have worked very well if we chose patient with a severe defect in the mechanical barrier, like a supine reflux or with a large hernia. So we looked for adult patients that had predominantly upright reflux disease confirmed by a pH study. And so we needed them to have more than 5.5% upright exposure time of reflux, and we didn't want them to be on a PPI. We excluded patients with LA grade C or D esophagitis, or those patients with a hiatal hernia greater than 3 centimeters. And we didn't want anybody who'd had a surgically altered esophagogastric junction. So Dr. Stein's patient with achalasia would not have been able to be part of this study. We also wanted to make sure that this wasn't just patients with rumination syndrome, because we know diaphragmatic breathing can help them. And we really didn't want them to take part in this specific study. We were interested in GERD. We also included healthy controls. So we wanted adult persons without a prior diagnosis of GERD, either clinically, or if they had an endoscopy for another reason, we did review those records as well. And we had to make sure that they didn't have heartburn more than once a week. So here's what we did. In part one of the study, we did a long manometry test, and some of our patients struggled with doing manometry. And in this study, we had the catheter down there for an hour. And we started off with a standard esophageal manometry. Then we did some maneuvers, the Valsalva maneuver, we did abdominal hollowing maneuver. And then we gave them a refluxogenic meal, and we repeated some of these provocative maneuvers. Then we randomized people. So we randomized people to either go directly into diaphragmatic breathing for 10 minutes and then stop diaphragmatic breathing and the probe stayed down for another 10 minutes. Or we randomized people just to have a sham intervention for 10 minutes, which was to listen to music, and then have an observation period for 10 minutes as well. After the manometry catheter came out, patients then went home. They fasted for 6 hours. And then they came back and we put a pH-impedance catheter down. And in the first part of the pH-impedance catheter testing, we left it down just like we do any 24-hour pH-impedance test. But on day 2, like you can see, this is a long pH-impedance test. We left the catheter down there for 48 hours. And on day 2, we randomized people again to diaphragmatic breathing. It's important to note that the patients who did diaphragmatic breathing during the manometry may not have been the same patients who did diaphragmatic breathing during the pH study. And during the manometry, we kind of just blended it in with the other maneuvers and we didn't explain much. But for patients randomized to diaphragmatic breathing during the second day of the pH study, we sat down with them and talked to them about diaphragmatic breathing, explained the rationale, and instructed them in the technique. And so we taught them diaphragmatic breathing, and we told them to do diaphragmatic breathing for 30 minutes or as much thereof as they could after each meal that they ate on day 2. The other thing that we did is that we gave them a standardized meal, my Minnesota refluxogenic burger meal. We gave them that meal on day 1 and on day 2, and they had the same burger during the manometry, which was typically done early in the morning so that they could fast 6 hours and come back in the afternoon for the pH studies. It was a burger breakfast and burger lunch and then burger next day too. Veggie burger for people who didn't eat meat. So the standardized meal was in there. So what did we find? So whenever we look at a randomized trial, it's always important to study who was in there. Are these people like my patients that I'm going to treat in my clinical scenario? So 23 patients, 10 healthy controls. The age was 58. The healthy controls were a little bit younger. The body mass index here is 29.9 in my patients, and we tried to match our controls pretty closely for that, which in retrospect may or may not have been a good idea. And you can see here amongst our patients as well that all had endoscopy and they had LA grade A or LA grade B esophagitis. Nearly all of them had heartburn. Nearly 3/4 of them had heartburn at least weekly, and predominantly they had daytime heartburn. But it's interesting that a lot of them also reported acid regurgitation symptoms. And as you can see, our healthy controls didn't have much of those symptoms at all because that was an exclusion criteria for this trial. When we look at table 2 here, this table looks at manometric features at baseline and in the postprandial state. And I don't know about you guys, but whenever I see a table like this, I start looking for a significant p-value. And that's something that I want to look at and see if it catches my eye. And we do have a significant p-value here. So if we look at the significant p-value here, this compared manometry between my patients with reflux and controls. And we noted, at least on our manometric catheter, that when you feed a patient with upright reflux, they have more pressure in the stomach than a healthy control. How accurate manometry is in measuring that is a whole nother discussion. And the older physicians here at Mayo Clinic who like the barostat might get shivers down their spine at me measuring gastric pressure on a manometry, but it was an interesting observation, I think. Here's a p-value that is not significant. In fact, it's very close to 1, but it's really interesting because this looks at the resting lower esophageal sphincter pressure. And look at this. Normal range, at least with the catheters that we use, is 13 to 43 millimeters of mercury. In my patients, all of whom had pathological gastroesophageal reflux disease in the upright position, they don't just have a normal resting lower esophageal sphincter pressure. It's kind of up there towards the higher end of the range. And guess what? It's exactly the same as my healthy controls. And as we go on in the study, you'll see that there's significant differences in how much reflux these two populations had. So again, it goes to show that the pathophysiology in this patient group isn't readily explainable, at least by resting lower esophageal sphincter defect. We didn't see any other major differences in manometric findings. We didn't see a lot of other significant differences in the manometric characters in the postprandial state either. So what did we find? Well, this is kind of a bit of a tricky graph to look at, but let's walk through it and so that you guys can understand this. What this graph shows, there's two panels that actually look pretty similar, but on the left we have controls, that's panel A. On the right side, panel B, we have our patients. But it doesn't really matter which panel we look at. What we can see is the first two columns show the number of regurgitation events detected by impedance during manometry in the 0 to 10 minutes after the burger, and in the 10 to 20 minutes after the burger. And then we look at the groups, whether they had active or sham. And you can see the people who had active treatment in the 0 to 10 minute range had way fewer reflux events during that time compared to the sham intervention. And we, in fact, saw exactly the same pattern, both in our healthy controls and our patients. So this, to me, what I would take away from this graph is diaphragmatic breathing in the acute setting can reduce postprandial reflux events, just like it did in our patients with rumination syndrome. Here's another graph, and I don't know who the reviewer was for my paper. That is meant to be unknown, but they kind of saved me. Because in this analysis, we did an analysis for total acid exposure, and we didn't find much. And my paper initially was written as reduced reflux events, but didn't impact the total acid exposure. But then there was a clever reviewer that said, look, hang on, you gave 2 standardized meals, day 1, day 2. Would you mind just looking at the 2-hour period after that meal, after the standardized meal, and see if that, and initially I kind of hummed and hard, and I thought I'm gonna have to open all these pH studies again, manually count reflux events and measure acid exposure time. It was kind of tedious, but in the end, it was the best peer review I've ever had, because here we actually saw that we could affect the postprandial acid exposure in a 2-hour window after the standardized meal on in the active group compared to sham. And so in this panel here, you can see the active group on the left-hand side. And so these were the patients that were randomized to doing diaphragmatic breathing. And on day 2, when they ate their burger, they had less acid exposure than on day 1 on average. Whereas on the sham group, which is shown here on the right-hand side, there really wasn't much of a difference. So what can we conclude at this point? I think we can conclude that diaphragmatic breathing changes the pathophysiology, it seems, acutely in patients with gastroesophageal reflux disease, at least in those who have predominantly upright reflux. This study shows that it impacts both the number of postprandial reflux events as well as postprandial acid exposure. What we don't know yet is the long-term effects. So are patients willing to do this? Will it actually reduce their reflux symptoms long-term? Will it actually reduce their total esophageal acid exposure long-term? And therefore, might a group of people be able to lessen or come off medications that they're using to treat heartburn? Those are all unknown questions at this point in time, although the data from Austria at least suggested that after a month, they saw a decrease in total acid exposure, but we didn't have any manometric assessment at that 1-month mark to kind of understand why that might be the case. We also don't know what the correct dose and technique is at this point. So in our study, we asked people to do 30 minutes of diaphragmatic breathing after their 3 main meals. And I think in an acute setting, when you're volunteering to take part in an exciting randomized trial, that may be doable. But how doable that is long-term for many patients, it's still an unknown. And whether we actually need to do it for 30 minutes and whether you have to do it at every meal is still an unknown. So lots of unanswered questions there about how to do this best. But I think with the data that we already have from Austria and Singapore, combined with this trial, I can't see any harm in recommending this. And I certainly think that in patients with an otherwise upright gastroesophageal reflux phenotype, that at least some studies suggest have a poor outcome when they receive a mechanical solution, that this would be a reasonable next step. Because these patients are also often refractory to PPI, in my experience. How can you teach a patient this? Well, in this study, I taught my patients diaphragmatic breathing, but there are multiple learning options available, including if you use that reference that I gave you from Andrew Ong in Singapore. He has a nice video. There are plenty of yoga instructors, singing instructors that know how to do this. There are online videos, physical therapists. And I'll leave you just here with the kind of simple diagram, which was the handout that we gave patients in our study, where we instructed patients just to take these slow, relaxed breaths, let the abdomen come out as they breathe in, and then when they breathe out, let the abdomen sink back down. And it feels quite foreign for a lot of the patients with reflux disease and rumination to do this initially. And I think that's my last slide. And with that, I'd like to thank you for your attention. And I think we're going to move into a Q&A type session here.
Dr. Hallen, thank you so much. That was just fantastic. And I think a really nice way of approaching reflux disease, and something I don't think that a lot of us widely pursue. So certainly something I'm going to be looking into. Joining us now is Dr. Smith, and he'll be helping facilitate the discussion. So now is a great time for all of you out there who have questions. Fire away.
Fantastic. I'll get things started while we're waiting for things to come in through the chat. Excellent talks by both of you. Dr. Stein, Dr. Holland, thank you guys for your insights, and certainly your reflux research that you've put in here. couple of questions. I'll start with Dr. Stein. So what you were describing at the beginning of your talk is, in some regards, irrational fear that patients walk in with. And they oftentimes, regardless of what type of a specialist you are, they walk in with what you might consider irrational fear about a number of different things. And one of the challenges I find is trying to use data to convince patients that their fear is truly irrational. So sometimes that often becomes a bit jargony when you really get into the data. What is your approach for starting the discussion with patients that have an irrational fear?
So I think grounding whatever their specific fear is in fact. And so there's often something in particular that they're scared of. Somebody in their family who got dementia, somebody in their family who experienced something. Listening and hearing and validating their concern, and then explaining exactly why the data points to something else. But I always validate the fact that, you know, if they're noticing a cognitive impairment after starting a medication, we'll check that out. I mean, if they're having, and many times I find, oh, I've been forgetful, or, oh, I'm having trouble with thinking. So for the people with dementia, they're experiencing a symptom. And so maybe that hasn't been addressed. The other part of the coin is they're usually speaking to their nephrologist, to their primary care doctor, or even their cardiologist, who has informed them there's a risk, you need to stop this medication. So I'm pretty clear in my documentation. You are taking a PPI because of this indication. You need it for this amount of time. We will decrease the dose in this time frame. If there is any problem with X, Y, or Z, we will meet again within 2 weeks. And I think that clear documentation of the why is really also important. And most of the time, when you ask a patient to tell their other physicians the why, their other physicians just going to get, oh, my GI doctor said to take this, and not, I had reflux disease that caused stricturing esophagitis, which was unmanageable, which is a totally different thing. And so actually for this patient who was 79, lovely guy, but couldn't follow a word that I said, I just called his primary doctor and had a little talk. And we talked, and she said, well, I'm really worried about him. His kidney function's been declining and I don't know what to do. There's no other cause. I said, okay, we can reduce the dose. We worked together and we got through it. But I think that kind of collaboration, it's rewarding, but it's also been lost a little bit in an electronic record. So I think it's important to bring that back.
Absolutely. On that same note, the patient who listens to what you tell them, you feel like you've gotten through to them, but you only find out on their subsequent visit that actually they listened, but they chose not to listen. They went home and didn't follow your advice. Does your algorithm for how you manage those patients that clearly you feel like you've made the breakthrough to, but they're not doing what you're asking them to do or what you're recommending, do you manage those patients differently?
Absolutely. So that happened today. I was doing an endoscopy and this person had this fibrotic webbed esophagus. It's terrifying to dilate. She's perforated before. And I went in and I said, God, she looks terrible. This is terrible. And when she woke up, I said, so you're taking your PPI medication, right? Like I prescribed that for you. And no, I stopped. I didn't like it. So we had a discussion and she said, I get side effects when I take this one. You gave me this particular one. I like that one. Her insurance had some trouble approving it. And we talked about it. There's a lot of cost issues these days where people just can't afford things. We don't have samples anymore, but I think getting at the underlying why, either they've spoken with somebody who gave them a concern, or a lot of people lost insurance coverage in the pandemic and they literally just can't afford the medication. So we figure out how to deal with that.
Makes sense. Very good. Dr. Holland, you mentioned early on in one of your slides the role of obesity in all of this. And what we really lack that would be ideal is a diagnostic test that tells us how much the obesity is contributing to the reflux. I always tell patients, since the majority of them have BMIs over 30, that I really lack that key piece of information of how much their obesity is contributing to their reflux. At what BMI do you start having conversations with patients about weight loss and the potential for their obesity to be contributing?
So I think you make a really good point to say that not all obese patients have reflux, but we know that obesity is one of the major modifiable risk factors. And the data in patients who can do it successfully is actually quite robust and quite remarkable in the sense of the reduction in reflux symptoms. So at what point do I start having the conversation? I at least start that conversation when patient's BMI starts with 3 something. I think 25 to 29, if somebody needs a mechanical solution for regurgitation predominant reflux, I think the outcomes are pretty good. Beyond that, I think outcomes rapidly deteriorate and durability of surgeries deteriorate. And so then we may end up giving a patient a surgery that's a good short-term solution, but not a good long-term solution. The challenge is, how do you get patients to lose weight? And there's many different strategies that have been employed there. I don't think we've come to the penultimate solution yet on the best strategy for getting motivated patients to lose weight. But I'm pretty disappointed by the data that shows that if your BMI is 40, for example, and we recommend diet and lifestyle as the only recommendation, only about 1 in 400 will actually achieve that normal BMI. And so that's a disappointing fact, but still a fact in America.
Yeah, I could not agree with you more. That is exactly the number that I use when I'm treating patients for hernias or for reflux. Is we know that intra-abdominal pressure starts to climb abnormally high once you start passing the 30 mark. And I've actually found it's quite helpful for patients to have some sort of a target where, while I can't definitively say that their reflux is going to get better, I can pretty comfortably suggest that their obesity or their intra-abdominal pressure is most likely no longer contributing to their reflux. And hey, let's get you to that BMI of 30 and see what we've got. And very often patients do have a noticeable improvement in the reflux as you get them down closer to 30. And that oftentimes serves as a good motivator.
Yeah, and then if they don't, then at least you have put them in the best position to get the best potential benefit from whatever mechanical solution that you do end up choosing for them.
Yeah, absolutely agreed. Now, the role of hiatal hernias and the efficacy of diaphragmatic breathing. This has been a fantastic talk and highly educational for me. As a surgeon, my bias is everybody has a hiatal hernia, which in reality, I know they don't, but of course, that's all I ever see. So at what size of a hiatal hernia do you feel like diaphragmatic breathing is not, it loses its potential for efficacy?
It's a great question, and we don't know the answer to that. In the fear of having a negative trial, we excluded patients with a hernia greater than 3 centimeters in this study. Would it work in somebody with a 4 or 5 centimeter hernia? We simply don't know. But I'm pretty pessimistic that that's going to be a good long-term solution to them. I think they probably have such a severe disruption of their esophageal gastric junction reflux barrier that it's much less likely that diaphragmatic breathing might help. Weight loss can still help, though. I've seen many patients with a 4 or 5 centimeter hernia, if they manage to lose weight, you can get them to, again, become a PPI responsive patient and manage their esophagitis. That's certainly not unheard of. And in terms of everybody having a hiatal hernia, I'm not sure whether you saw the study where we took people with a manometry catheter and had them run on a treadmill. And I mean, even in healthy people running on a treadmill, you can get a 1 to 2 centimeter kind of discrepancy between the crura and the esophagus. I think you can reproduce that, but that's probably not pathophysiological for severe reflux disease, I don't think.
Yeah. It would be fascinating in your guys' studies to try to evaluate, does vertical herniation versus scope diameter matter in terms of the loss of efficacy of diaphragmatic breathing? Because you would instinctively think it's the latter, even though we measure everything with the former.
The endoscopic assessment of hiatal hernia, I don't know where to start. It's often quite disappointing. And I have to say that in 2021, if I'm really interested in hernia anatomy, an upper GI fluoroesophagram is an amazing study to tell me the anatomy.
Yeah, agreed. Back to the gold standard. Absolutely agreed. So a question for both of you. I don't see anything that's popped up in the chat box, so I'll keep moving. Question for both of you. When you're trying to manage patients with lifestyle intervention, do either of you talk to or counsel your patients about portion control or the style of their eating? We've talked a little bit about weight, but we haven't, and I think often don't, talk to our patients about how they eat and how quickly they eat. We do talk to them about what they eat, but we don't talk to them about the speed or the amount that they get down over a certain period of time. And I bring it up as a bariatric surgeon that thinks about and discusses this a lot with my patients. It is so common to find patients who clear their entire plate in less than 5 minutes. And so do either of you counsel your patients about that? And if so, what do you try to bring forth in terms of meaningful change with them?
I'll start, but yes, every patient, we talk about their last meal, what did they eat? And then if there's family present, which is not possible as much in the pandemic, and yet through telemedicine, I can see into their house a little bit and get a window into their life. And you ask that question, do you finish first? Do you chew well? Do you, how are you eating? Are you eating multiple meals a day, or do you just get the one big meal and eat it right before bed? And when you start talking about those specific details with patients, I find you get a lot of granular data, and then you can help guide them. Even brilliant physicians who have come to me, or health administrators who know all the data, they're all doing one or two things which are tipping the scales for their reflux: late night eating, late night snacking, that extra cup of coffee within an hour of bed, or just sodas. Or my favorite was somebody who was having trouble with belching, who was filling himself with carbonated beverages all day long and wondering why he had so much to belch. But they don't always make the connection, and sometimes you can help them. And it's not necessarily a punitive conversation, so it's not a finger waving, but it's just an exploration of what could we try to do? We've tried this, it's not working. What am I missing? And they'll always tell you what it is. So,
Dr. Stein, I had a question. You had referenced SSRIs and TCAs. How do you use those in your practice for patients with reflux disease?
Liberally. It's a pandemic and almost everybody's got an element of anxiety and depression. Many people have heard about Meghan Markle and other famous people seeking care, and it's become a little bit more acceptable to say that the pandemic is causing stress. A lot of my patients who have been home during the pandemic have found their correlations between stressful events and symptoms, and have actually been more open to receiving care. So for somebody with anxiety or depression, obviously you want to screen for that first. You want to treat that. And if somebody's got a history of bipolar or a psychiatric history, you want to kind of bring that into the conversation before you go suggesting medications that might set them off. But if you're having refractory symptoms and you know the PPI is controlling whatever the reflux is, or you've diagnosed that on reflux testing, they're not having reflux events or measurable acid reflux and they're still symptomatic, I try to make the meaningful connection between symptoms and stress, or symptoms and anxiety, because that's when diaphragmatic breathing might be really helpful. And they start to notice a connection, and they have something they can do in the real time. But for people who aren't better, then sometimes something that's going to be a neuromodulator to reduce that sensitivity, especially if they're very accurate reporters. I compliment them on their superpower of having the ability to detect every single reflux event, which is not something that's common, but you don't always want to feature your superpower. So then I give them a medication to modulate the nerves. People are growing a little more accepting in the last couple of years, and I'm happy to see that, because it really helps when you take a medication to neuromodulate hyperactive nerves.
So I think Dr. Katz has a question here in the chat window. He's saying, who pays for training in DB? I don't have a nurse who has time to do this or to follow. So I'm going to give you guys a couple of resources that you can use for your patients in real life patient practice. Number one is nearly every patient has a smartphone, and they can download an app that is called Breathe 2 Relax. With breathe, then the number 2, relax. This app was made by Department of Defense for treating PTSD in vets, and it will teach patients to do diaphragmatic breathing. It'll remind them to do it, and it'll help monitoring their anxiety levels as well. The other name to look up, I think the video is on YouTube, is Dr. Megan Reel. And if I'm correct, she's a psychologist in Chicago, and she has a very nice video, and I believe it is on YouTube, that is an excellent patient resource, cost zero. So I think explain the rationale to your patient. I do think you have to dive into a little bit of the pathophysiology and explain why you think this breathing technique might help their reflux, maybe with a simple drawing of the esophagus and the diaphragm. And then I would use that app or that YouTube video. If you have a psychologist or a yoga instructor that can help you out, that's great. But even now in the pandemic, you can literally log onto your phone or on YouTube, and I think you can get started on this process.
All right, Dr. Newhams, back to you.
All right, folks. Well, we are at the 8 o'clock mark. I think we've touched on all the questions, and I think some fantastic questions were answered in overall discussion. I am grateful to all of our panelists tonight, Dr. Stein, Dr. Hallen, and Dr. Smith for facilitating the discussion. We will be carrying on in April for part 2 with AFS webinars for more therapeutic approaches to reflux disease. So stay tuned for that information. Thank you all. Have a wonderful night.
Thank you all.
Thank you. Thanks for having me.